rise of chronic illness has brought with it a hunger for unifying theories. Patients want explanations that validate their suffering, and clinicians want frameworks to guide treatment. Researchers want models to organise diverse findings. And into this space comes the cell danger response hypothesis, embraced by some as a way of grounding chronic dysregulation in a cellular biology and mitochondrial signalling. It's an elegant metaphor. The cell, confronted by overwhelming stresses, shifts into a defensive state. And if this state persists, illness ensues. Yet, like many elegant metaphors, the cell danger response risks being mistaken for a master mechanism. And when we do this, we confuse outputs with causes. Mitochondrial shifts, cytokine surges, and biomarker fluctuations are real, undoubtedly, but they are downstream reflections. They are not the organisers of illness. And to truly understand chronic dysregulation, we need to climb back up the ladder into the realms of threat appraisal, trauma, implicit memory, affect regulation, meaning, and from the vantage of depth psychology, affective neuroscience, and trauma science. It becomes clear that symptoms are, in this light, not malfunctions. They are signals, communications from the body-psyche system, attempting to complete unfinished processes and restore wholeness. The cell danger response draws from well-established observations. Damage-associated molecular patterns, DAMPs, stressed or injured cell release signals such as ATP, HMGB1, and mitochondrial DNA into the extracellular space, triggering immune responses. Mitochondrial shifts. Cells under duress downregulate energy-intensive processes, altering redox signaling, ATP metabolism, and gene expression. And inflammasome activation receptors like P2X7 and NLRP3 mediate inflammatory cascades in response to extracellular ATP. These mechanisms are robust and peer-reviewed. There's no doubting of their existence, of the fact that this is fact. Where the model overreaches is in presenting them as the root cause of chronic illness. Most cell biologists treat DAMPs and mitochondrial shifts as correlates of systemic states, not as the prime mover. And this is to confuse the cause and the correlate. Pioneers in affective neuroscience like Jaap Panksepp showed that the mammalian brain is organised around primal affect circuits: fear, rage, care, grief. Dysregulation arises when these circuits are repeatedly activated without resolution, interrupted, curtailed. And mitochondrial shifts then reflect the metabolic translation of these emotional states. The driver is emotional repression, emotional appraisal, not ATP. Antonio Damasio's somatic marker hypothesis describes how the brain assigns value and salience to experiences through embodied signals. Chronic dysregulation arises when old somatic markers of threat dominate current appraisals. Again, mitochondria follow the lead of appraisal circuits in the amygdala, hippocampus, and prefrontal cortex. In trauma science, Bessel van der Kolk et al. Emphasize that trauma is not an event, but a state of incomplete resolution, and when fight, flight, or freeze responses cannot finish, the autonomic nervous system installs a chronic bias towards hyper or hypoarousal, and this creates the conditions for systemic inflammation, altered immune tone, and metabolic shifts, of which CDR is one representation. In all three domains, the organizer is experiential and relational. Biology is the echo, not the original voice. Symptoms are signals, not errors, and from a depth psychological lens, symptoms function symbolically. Carl Jung observed that the psyche produces symptoms when shadow material, feelings, truths, or memories excluded from consciousness, repressed, demand recognition when the shadow is too full. The symptom is the voice of the shadow, made somatic. Fatigue can be the body enforcing boundaries where the psyche could not. Pain may embody anger that was forbidden. Anxiety often too signals mobilized energy, desperate to outlet through a body from a shadow that is so dense and an allostatic load that is full to capacity. And dissociation preserves safety where overwhelm is inescapable. All of these symptoms are echoes themselves of repressed emotional charges, of incomplete survival events that were not allowed to finish and now are held in the body, held in the nervous system, held in the mind-body shadow. And this is the cause of dysregulation, and this is the cause of the observable and very real changes that we see in the body. So in this framing, biology does not malfunction. It performs a communication function, keeping the organism aligned with survival needs and unfinished truths. Meta-analyses consistently show altered heart rate variability and disrupted autonomic balance in PTSD and chronic stress. This dysautonomia is one of the most reliable biological signatures of trauma. Chronic hyperarousal or shutdown patterns recalibrate cortisol rhythms, HPA axis output, and inflammatory tone. These changes are now well established in trauma literature. These are all consequences, not causes. And cellular consequences include mitochondrial shifts. As I said, damp release and altered redox signaling follow from this altered autonomic and endocrine milieu. In other words, the cellular level reflects the nervous system's state, and the nervous system is in a state of dysregulation because of the emotional charges coming now into consciousness and have been pressing from the unconscious and held there for so long. Held in the nervous system denied the important regulators of emotions that have been held back for so long. And this cascade flips the CDR narrative on its head. Chronic illness is not primarily cells stuck in defense mode. It is a person stuck in unresolved survival states with cells faithfully mirroring that truth. So why do these theories gain traction? Well, patients with poorly understood illness feel seen when biology is evoked. We are experiencing these symptoms in our biology. It seems logical. We are materialists by nature in this day and age. And there's a reductionism bias. Medicine is trained to privilege molecular explanations over experiential ones. If mitochondria are the problem, perhaps drugs or supplements can fix them, and there is an intervention lure here. The ego doesn't want us to go back and feel and experience that which was once put into the shadow because it was too overwhelming. We will always, from these childlike parts of the ego, seek to avoid the pain we once had to escape, that were too overwhelming to experience. And of course, there's a narrative elegance to understand things from a biological perspective. The cell is stuck in defense mode. All of these other aspects that would explain what is actually ultimately causative. It's simpler to explain it this way than the psyche is representing unfinished relational truths. It's too much for most people conceptually to understand. Yet elegance should never be mistaken for accuracy. We need an integrated framework, and a coherent model must respect both the biological and the psychological. After all, it is a mind-body condition we're talking about. The following hierarchy reflects what trauma and depth psychology, along with neuroscience, actually show. Meaning and appraisal. The system interprets experience as safe or unsafe, shaped by our own personal history, including attachment, trauma, and all the other things we talk about here. Our autonomic state. The nervous system sets baselines: fight, flight, freeze, and collapse. And neuroendocrine and immune responses, hormones and cytokines organise accordingly. Cellular metabolism, mitochondria, redox state, and damp signaling reflects the higher layers. And symptoms. The body speaks the truth through pain, fatigue, anxiety, or shutdown. If biomarkers are not the root, then the clinical focus must shift. Relational repair, to look at safety in attachment, recalibrating appraisal at the highest level, reconnecting with ourselves, becoming the safe witnesses of our own bodily experiences, being able to re-embody with ourselves. And this will necessitate and support somatic completion. Peter Levine's somatic experiencing and related methods allow incomplete defensive responses to complete. The charges are able to move through the body. And of course, as a result, re-regulate a system that has been dysregulated by necessity through repression. And of course, the symptoms will then reduce. And all of these biomarkers that are very real and are being identified in this patient cohort will resolve. It's a bit like saying in the old days, because someone has depression and they look for biomarkers and they see chemical changes, they mistake these for the cause. No, it's the other way around. It's because we're depressed, we have visible changes in the brain and the neurotransmitters. And we need to re-author meaning, updating core appraisals. Rest is safe, anger is valid, and this dissolves chronic vigilance. And we have to do it by actually showing it, by doing these things in an embodied state, often for the first time in our lives. Within a framework of structured rhythm, predictable schedules teaching the body baseline safety. Without these elements, without them being addressed, biomarkers, when these are addressed, biomarkers will typically, as I say, normalize over time, not necessarily automatically in a straight line, but they will, because they will no longer, as I say, present in the body through symptoms because of dysregulation, because of initial repression of this core emotional material, effectively our life force, which has been choked up, creating a backlog and overwhelming us to the point where this is the resultant effect. I fully understand that this position will be, and anticipate objections to this. People will say, but mitochondria change first. Automatic appraisal can shift metabolic states in milliseconds. Order of change is not proof of causality. And interventions improve biomarkers. Yes, of course they will. Often true, but without actually addressing appraisal and safety, these improvements will be short-term and relapse will happen. I have seen it again and again myself. This is what I experienced. We have to get to the root. And it was without addressing, doing the shadow work, actually looking at it as a mind-body condition, not a brain-body condition, we will simply be going round in circles. And then this false dichotomy of saying, well, this is just psychology. Meaning, memory, and appraisal are embodied neurobiological processes. This is real. This is not, we don't think emotions. We don't think of any of these things. This is held energy in a nervous system. And this has very real consequences downstream. And to treat the deeper psychological effects, to understand the mind is actually expressing now through the body, is to treat the biology at its highest organizing level. The cell danger response offers a useful map of cellular processes under stress, but it is not the territory of chronic illness. The true organizer of dysregulation is threat appraisal shaped by lived experience, trauma, and psychological meaning. Biomarkers are important, but they are reporters, not rulers. And symptoms are not errors, they are messengers. Healing does not come from silencing them. That's just more repression. But ultimately from listening, allowing, and supporting them to finish what was once started to the point of completion. So beyond mitochondria, beyond biomarkers, beyond all the symptomology that we are experiencing here, symptoms have to be seen differently as symptoms, not malfunctions.